Okay, so have a Val Presa. Is it Presa or Presa?
Presa.
Presa.
Yeah, like
Okay.
pray, sa.
Okay, got it. So
But
there's an emphasis on the last sa. Presa.
yeah,
Okay, great. Okay.
but
S-
people say it all different ways, and I
y-
understand.
You get used to it. Okay, got it. Okay, so I first met you at Blue Stem when you were finishing up your hours,
Mm-hmm.
right?
Yeah.
For, and I don't remember your credentials. Like, what's your letters after your name?
Marriage and family therapy,
Okay,
so
marriage and family.
LMFT.
Okay, cool.
Mm-hmm.
All right, you seem like an LMFT. My that seems like a that's anyway. I'm not gonna get
There's
off
a
on that.
type, isn't there?
Yeah,
Yeah.
well, yeah, it seems like a lot of really good training. So, um, so now you work at,
Here at Perspectives, so I have
and
private practice with three other colleagues,
yeah,
and yeah, we've been here for about 6 years now.
yeah,
So I was actually at one point I was working at Blue Stem and here and Fernbrook. So
wow,
there was a period of time where I was shuffling around a lot.
yeah.
But yeah.
And so, we're gonna learn about somatic experiencing therapy today,
Yeah.
which you've been. When did you first start studying that?
Somatic experiencing, I first became aware of back when I was 28, when I went to therapy myself. And I didn't know that my therapist was using that approach with me, or as part of his approach, until much later on. And so when I discovered that, I decided I wanted to do that. But then I realized that in order to do that, I needed to have other credentials and get into therapy or something along those lines. And
Okay.
so I did some research and just decided to be a marriage and family therapist, and then I had to have my license before I could apply to the program to learn somatic experiencing.
So that was from the get go. That's what you were planning on doing.
That is that's my goal.
Wow. I thought it was, see, this is the ignorance of prescribers, is that, or at least this prescriber, I thought it was something relatively new. I thought it was sort of a newer thing. So, I don't, I don't know if you care about being dated, but, what, like, well, do you know what year that this was a thing?
So that's, my brain does not hold on to numbers
Okay,
and
sure.
things very well, but it's quite old. It's been around a while. Peter Levine is the scientist doctor who developed the approach, and he's got a great story. And I don't want to butcher his story, but from what I remember of it, he was doing work with patients and also was doing some comparison to what he was seeing out in the wild with animals when they were under stress and how they responded to that. And that idea that, how is it that a zebra can go through a really stressful event and not necessarily develop PTSD and have those sort of symptoms carrying on in their lives that we humans do. And so he really studied the physiology of it and then started applying some of those ideas in his practice. So but it's been around a long time and has developed and changed. I really have a lot of respect for him. As he learns more information, he changes things. It used to be that with somatic experiencing, we're kind of going for release of trauma. So catharsis maybe, like you want the person to sort of experience this sensation in the body and have a big event that releases the trauma and the energy. And then what he found out was that happened, but then they go back to their life and it starts to build up again and build up again, where we found that if it's titrated little by little by little, it's actually more sustainable and that the system adjusts to it better. So long answer, but
what ages is it for?
Any age. It's really working with the nervous system, and so maybe little tiny babies. Hopefully they don't need it too badly, but yeah.
Okay, well, how about you jump in and tell us what it's like? Tell us what it's about.
So I've been working on my elevator speech for somatic experiencing for a while, and I still don't have it down pat. But we're talking about, again, the nervous system. It aligns really well with polyvagal theory, Are you familiar with that at all?
I know that there's a vagus nerve that can calm people down, and it's activated when we bear down, like to defecate, and then I also know there's other ways to activate it, and it can even cause like fainting for some people, like if it's activated. So I know that there's that vagus nerve, but I don't know what polyvagal theory is.
So it aligns well with that, talking about the nervous system and how our nervous system autonomically, so on its own, balances out the systems that we need within us to keep us alive and safe. And mainly safety is what we're talking about in somatic experiencing. So we want to think about sorry, I get like, where do I start? There's so much information. When our system is under threat, we do all sorts of things, like our heart pumps faster, our digestive system will shut down, so we might get dry mouth, and like right now I'm experiencing a little bit of
So like some people call this like the fight or flight response, like this is the somatic nervous system,
right?
Yep. Okay. So you're talking about the dry mouth and your gut shuts down. You're basically prepared to fight or flight, not digest. Your pupils might open wider, so we can see in the dark as primitive humans. And
exactly. And so what we want to do is kind of experience safety to calm those things down, because that's what's happening for me right now. Is I'm noticing a little bit of a freeze response. My brain isn't processing the words and the thoughts as well, because I'm a little bit more in my freeze response, like a little bit of a oh gosh.
Sure. Okay.
So, and that's just because
I know how to make it worse. All right, Val, just use your stuff on yourself right here while you're being filmed and recorded. No, I'm just kidding. Okay, but
well, that's what I was actually going to say. It might be helpful for me, and it's a good way to demonstrate it.
Great.
So one of the first things that we'll do, that we'll teach in somatic experiencing is how to do that. So for me right now, it's the being observed and being on the spot. No human being likes that. Our nervous systems don't like that. We don't like being singled out, and I mean, some people do, but a lot of us just don't. We don't like it. We like being in our pack. We like being supported, and that helps us to feel safe. And so I do feel safe with you, and I know you, but I'm also feeling like I need to have answers.
Sure.
So one of the things that we can do to help us get out of that mode is to move our head around. So just allowing myself to sort of look around the room and take in the different lights and to listen to the sounds. And I'm even having trouble doing that because I'm aware that I'm talking to you and I'm wanting to be attentive to you. So if we were like a deer in the headlights, if a deer hears a noise, they sort of freeze. The sound might be over there. And so they're hearing it. And they freeze, and then they turn their head and look, because they might have seen something out of their peripheral vision, but that's not going to tell them what it is, and it's not going to tell them how fast it's coming towards them. So then they'll turn and they'll look, and that'll give them more information, and then they'll stay frozen for a minute to see, is there a threat or is there not a threat? And we can turn our heads even further, and we can do the same thing. And so if I can turn my head and I can look up and see details and notice, how far is the ceiling from my eyes, and what kind of light is coming into my vision. And then just the turning of my head and the looking around tells my brain, tells my system that I'm safe enough to do that, that there isn't really a threat. I don't have to have that tunnel vision that we get when we're in a threat like a deer. And I can feel that settling down already, and I can use my 5 senses, and I'm smelling the smell of the audiovisual stuff that brings me back somehow to childhood, maybe my record player, and the touch of the soft couch, and eye contact with a friendly face, so that all helps my nervous system to feel a little bit safer. And that would be a great example, actually, of somatic experiencing. So what happened for me was my system got activated. There was a little bit of a sense of threat, but obviously you're not a threat. This topic isn't a threat. It's just my nervous system naturally responding that way to being on the spot.
Mm-hmm.
And then I was able to orient and talk through it, and my nervous system calms down a little bit.
Mm-hmm.
Now you might ask me another question that'll send me back up into activation
Mm-hmm.
again, and that's sort of what we do in a session. So in the beginning of getting to know someone, it could be just you're in this new space with this new person, and we would orient and we would learn that. And then we have some words like what was going on in my body. I was noticing inside that my stomach was a little grippy, and I felt a little tingly sensation in my arms. There was a little shakiness going on. I could hear that in my voice. I noticed that there was not as much connection to my words and my thoughts. I was getting a little bit lost.
Mm-hmm.
I think I lost a little connection with you because I was more overwhelmed with what was happening.
Mm-hmm.
Yeah.
And you're being very articulate about your experience. I imagine in your time as a therapist that you probably have worked with people who they are far from being able to notice what senses they have in their body. They might not even be aware they feel threatened. So, like, let's say you had a new client who, what you were describing, they understand it, but they are like a novice at so how do you work with people like that?
Well, most of us are like that because I don't know very many people who are raised and their parents are, maybe you do, and I've tried now in the last few years, but we don't usually, when our kids are having a tough time, say, how are you feeling in your body? And like, oh yeah, you're upset or that hurt, and what's happening in your legs right now? So most people are pretty novice at it. So when they come in, we just talk about, I'm going to ask you questions like, and it might sound kind of crazy at first, like, well, what's happening inside your body as you're telling me this story or as you're sitting here? I have a menu of words that describe, internal sensations like tingly or hot even, or tight or constricted. Just a whole menu that I can give them a sheet and say, is there anything on this that you might be experiencing somewhere in your body?
Do you have it handy?
I do.
I'd love to see it. Yeah.
Let's take these off. Yeah, it's got achy and airy and alive, bloated, breathless. It's pretty long.
Can I see it?
Yeah.
Cool. Okay. Elastic.
There's one on there called Quaker. I'm not quite sure what that means, but people can get creative with that one.
Maybe they feel like having cereal.
Yeah.
Okay, well this is it. Okay, so one thing I'm noticing is these aren't, like, at least as far as I'm concerned, stereotypical emotion words. So for example, happy, sad, frustrated, that sort of thing. So frozen, gurgling, hard, intense, sticky, spinning, spacious. So just looking over this list of, I'm going to guess 60 words or so, you can see that they have much more to do with, at least what I'm thinking of as physiological sensations, crampy, cool, clammy, quivering. So that's something I'm noticing right away. So is it fair to say that this therapy really centers around what one's, it seems especially their physical sensations are. So it's about noticing that stuff. Okay.
Yeah. Yes, because that's the part that we tend to not notice. And sometimes those feelings can be even more frightening to us. When my stomach or my chest is tight, that can feel uncomfortable and almost scary, which can send my body into, if I think, oh my gosh, what's wrong, then I'm going to go into more escalation. I'm going to get more activation, and that might increase it or make other more uncomfortable feelings come up on my body or sensations. So I make a point of calling that sensations versus emotions, which are happy, sad. And so in somatic experiencing, it's like a star, and we call it SIBAM. It's an acronym. So sensations are those clammy, those types of things. Image is the I for SIBAM. Images, we will talk about, as I'm smelling the smell from the audiovisual, the image that I get in my mind is actually of my childhood living room. And my record player came in my mind. And so I'll ask clients that. Sometimes they're saying, I'm feeling sad, and I'm feeling this sort of pit in my stomach. And I'll say, is there an image that comes to mind? And sometimes there is, and sometimes there isn't. And then if there is, there might be some information there. The experience that I'm having right now of sad, because that's what's actually happening in my body right now, that emotion, and that pit in my stomach, that's a sensation that's happening in my body, might be tied to a memory that happened back when I was 5 years old. And that image might give me some information as to what that is. And then we're really experiencing the sad and the pit in the stomach that's connected to that thing from back there, and we can then say, oh, okay, well, that feeling, that sensation is connected to that. And right now, we're here. We're in this room, and we can do that orienting thing again. That lets us know we can work on that, we can talk about that, but we also are safe right now. And so we're slowly teaching the body to learn how to be present in this moment while still having these memories and having these experiences from back however long ago.
Okay. This sounds like a lot of mindfulness. So I know, like, I have a basic knowledge of certain therapy techniques, and so this is making me think about grounding, which is, as far as I know, when you're working, not necessarily somatic experiencing, I don't know, but in some forms of trauma therapy, they'll start with teaching the client, how do you ground yourself? So that is, if you are perhaps dissociating, notice the feeling of the ground under your feet, or this sort of thing. So where, like, because if that's all this was, well, then it would just be grounding, right? But this is something, somewhere these split off somewhere.
Yes. Yeah.
Or maybe they don't. I don't know. You're the expert.
Well, the grounding can help us to be present.
Yeah.
So you're right. Like there's this, if I'm telling you a story about something really hard that happened, it might be something that happened today that made me really upset, but there might be more reason that I'm upset about it today because it's connected to a trauma from my past. The grounding piece can help me get centered right here, right now, and then we can decide, do we want to go back and talk about that thing that happened in the past from this safe place? Does that answer your question?
It does, and I'm wondering, okay, so let's say, is there a goal, like you're working with a client and they have this trauma, and let's say that you're with them for, a year or year and a half, and their consistent answer is, no, I don't want to go back to that place. Is that okay? Are they still progressing?
Yeah, so with somatic experiencing, it's so gentle. There's never a demand. It's always an invitation. One of the main things with trauma is that things happen too fast. The person doesn't have control of that or the situation. Usually there was an inability to defend themselves somehow, whether it was an accident that they couldn't avoid, or maybe they were a child and they were powerless to the person who was either, disciplining them somehow or telling them what they had to do, without going to specifics of all different types of trauma that can happen to someone. So in here, it's important that this happens at their own pace, and that everything, including, do you want to tell me what sensation is there a sensation that it's up to them? It's always an invitation.
I see.
Yeah, just a curiosity.
Okay. And so, like, the benefit that someone would achieve from this, I want to stick with trauma for a moment, is they're aware of their body, and let's say that they have, as far as I know, they're called a trigger for a traumatic reaction. Maybe it's a loud noise or something. And they might have that fight or flight response come up, or otherwise feel very uncomfortable. They were triggered in this way. So is the way in which the client gets better is that those become less bothersome. Like in those moments, perhaps they might notice their, what's the acronym again?
SIBAM.
SIBAM. Okay, so there's sensations,
Image.
images,
Behavior. Affect. So
affect.
That's the emotion.
Okay, and then
Meaning. So what do I think of this? What meaning do I make of this? How do I
Okay.
understand it?
So
The
they-
story.
so they have that, and you're using the techniques that you teach them, and then what happens that next to that person?
Well, I think it's really helpful in the sense that, for one, if we can separate somatic experiencing, they use the word uncoupling or coupling. So sometimes we have things that are undercoupled. Like I might be undercoupled to the fact that I'm safe right now. My body is reacting to something that happened long ago, and I'm safe right now. So that might be undercoupled. So we want to work on coupling this awareness that I'm here right now, and that's from back then. Or it might be overcoupled. Like that would be more, I think, like a trigger. If someone says, I'm always about examples, but I'm having trouble coming up with one.
Maybe shut up. Someone says shut up.
Yeah, someone shut up, and I have this big reaction to that. It really hurt my feelings. It's so offensive. It may not have been that offensive right now, but that's my reaction because of this stuff that happened, 10 years ago that was really hurtful to me and was life-changing. But maybe I don't even have an awareness of that, or I don't see the connection to that. So that would be overcoupled. My body is reacting, my behaviors are reacting in a way in this moment with you, versus there's nothing in my awareness that's actually about something that happened before. So uncoupling that can help the person say, oh, yeah, in this moment this happened and this didn't feel good to me, but that not good feeling isn't about now. It's about that. And in the moment it helps, because then I can go, oh, I don't need to react this way, so I can control my behavior better. The meaning that I make of it in that moment is different. I can go, this means I might have to work some more on that thing that happened 10 years ago and figure out what did I need to do to defend myself back then? What can I do now? What's necessary to do now? Does this mean this person is being mean to me? Well, shut up's not a nice thing to say, but,
They might not have the same control over you that
Exactly.
one did when you were younger. Okay.
Exactly.
So it also sounds like, at least in the work you do, that's a good example that you use this comment about we may have to go back and do some work on that. And is that sort of, that might look differently than what we're talking about right now? Like, is that a different type of work if someone is consistently and perhaps severely triggered by this thing? Like it sounds to me like perhaps they're not, there's this unawareness of what it's coupled to, and then there's work done on figuring that out. Am I following you right?
Yeah, that's a great question. So work meaning, in here, we might say, hey, let's talk about that thing that happened 10 years ago. And the person might start talking about that. And then we're doing SIBAM with that, not about the thing that happened today. And we do that slowly. The person might start telling the story. So we're doing, just as you're starting to think about that thing that happened 10 years ago, what are you noticing in your body? What are the sensations? Well, I'm feeling really agitated. Like I know this is going to be. Okay, so where is that agitation in your body? Is there a particular place? Like even as I'm pretending that I'm agitated, my hands are going like this. So I might say to the person, let's just stay like this for a minute. What happens as you stay with that? And they might notice that, well, I have this like tension all up in my arms, and I might say, well, is there an image that goes with that? Yeah, like I just want to, or an impulse, like I just want to like reach out and, there might be that would be more of a defensive reaction. So I might just say, okay, let's just stop there and back up. So what was happening right before this all started? And then we get that activation, and we settle down.
Mm-hmm.
And each time we go a little closer to like what actually had to happen or the bad thing that did happen,
Mm-hmm.
the person gets to release a little bit more of that activation. That energy shows up.
Mm-hmm.
We know what it is. We know what it's related to. They get to feel it.
Mm-hmm.
Sometimes people, when there's a lot of that activation that shows up, there's a little afterwards, there's a little bit of shakiness that comes
Mm-hmm.
in. They'll be like, I don't know, I'm just shaking.
Mm-hmm.
And that's a good thing. That's sort of that energy built up and it releases a little at a time.
Mm-hmm.
Then we know we're getting, at 10 years ago, that's the work, sort of, to release that energy that maybe was there then that didn't get released because they couldn't defend themselves somehow.
Mm-hmm. Sure.
Yeah.
So as you're in that example too, they, it sounds like part of it is you're not, like if they say they feel tense or, you know, their chest is getting tight, is even just thinking about it, correct me if I'm wrong, in somatic experiencing therapy, it sounds like if that is noticed, there's sort of a, you know, implicit or explicit, okay, we're not going past that moment yet then. We're going to sit with this and or do some of that, you know, parasympathetic activation where we look around the room or, you know, this sort of thing.
Right.
Okay.
Right.
In other words, there's not a part of somatic experiencing where the client might say, I'm feeling tense even thinking about it, and then you just say, okay, go on with the story.
Yeah, I might say to them, we kind of, we gauge it a little bit. You know, the person might say, I'm feeling really uncomfortable, like my heart is pounding, I have this tightness in my chest. Well, that doesn't sound pleasant.
Mm-hmm.
You know, I might just say, is there a part of your body that has a little more neutral? And then lean into that a little. And then once they're in there and it's like, okay, yeah, my foot is more neutral. What are you noticing there? And we spend a little time in the foot.
Mm-hmm.
And then it might be, okay, and how is that chest tightness? And they go back, it's not as bad.
Mm-hmm.
Oh, okay. So do you want to continue telling me the story? So we might continue going on with it, but once they're able to be in the story and their body isn't as uncomfortable.
Mm-hmm.
So we don't want to just get to a point where, oh, there's uncomfortable and we're not scared to go in it, but we want to check. And are you feeling, I'm always inviting, are you okay with going forward? How does that feel right now? And sometimes people want to blow through, you know, like a lot of times a first session with someone, they want to just tell me all of it. And it's work to say, okay, well, I know you really want to tell me all of this.
Mm-hmm.
And I want to hear it. And also I know that it's going to be better for your system if we take it slowly and we hear it a little bit at a time, but it's going to have to be up to them. And sometimes we have to hear the whole story and they have to tell me the story, and then we can go back and say, okay, can we try this again?
Mm-hmm. Yeah, but I would imagine for the same reason we're talking about, some people would want to get through their story and show that sort of physiological difference between them. I don't know what it's like in your office, but I could see someone having a story, they just want to get out first and then do the thing. And I imagine there might be a physiological release with that, getting it out and then going through slowly. Is that, am I thinking about this the right way?
Yes, absolutely.
Okay. Yeah. Okay.
Yeah.
Okay. And let's see. So, I wanted to ask you about dissociative experiences during therapy. So that is, you're working with a client who has a trauma history, and they get stressed to a degree where they start dissociating. That is, that they might genuinely perceive that their surroundings aren't real, or they're not real. It can be very overwhelming and uncomfortable for some people. Other people don't remember what was happening when they were dissociating. But what's your role, or what can your role be in those situations?
Well, when it's actually happening, a lot of the time is just me being grounded. So there is that connection, that sort of co-regulation that can happen.
Mm-hmm.
If I'm grounded and I'm okay, you know, I might offer to place a hand on their arm, or, you know, I might invite that, and just being present and inviting them to orient. So And it may be, like I said earlier, kind of looking around the room. It might be like holding a rock. It might be doing something physical that lets their body know that they're here and helps them to try to become more present in their body.
Mm-hmm.
But mainly just really normalizing that as something that our system does to help keep us safe.
Mm-hmm.
And to remind them that, oh yeah, like this is something that at some point in your life your system learned to do this to be as safe as possible,
Mm-hmm.
to not experience something really painful or frightening. And, is that something that is necessary right now? It might be a question that I'll ask. At some point, sometimes people just can say that to themselves. This is happening, and this is normal, and this is okay.
Mm-hmm.
And it may not be necessary right this minute, but not if they're already in that sort of dissociated stage.
Sure.
But a lot of times, some of the work that we'll do is to try to notice what happens right before they go into dissociation. Like, what is that one thing or two things or three things that you might notice in your system that tell you that the next step is going to be dissociation? Because if we can work with that, then we can figure out, well, maybe how do I back off of that? Or how do I tell myself in that moment that that's not going to be necessary to do? I don't have to dissociate because I am safe, even though my system is telling me something different.
Mm-hmm. Okay, and suppose that this is, again, I'm thinking about a patient with maybe chronic dissociation that's impairing their functioning. Okay, maybe they are not able to keep a job, for example, because that happens so frequently for them. They can't function. So, and let's say that client's like, I don't know what happens, or it seems like everything causes it. How do you work with that?
Yeah. I would say, well, I don't expect them to know the answer to what happens right before.
Mm-hmm.
Again, really normalizing it with someone that this is their nervous system's way of staying safe, and they might be misinterpreting a lot of things as unsafe that are actually safe. It could be stuff going on in their body as well as things outside in the world, as well as interactions with other people or thoughts that they're having. So in our time together, we're noticing together, like even in here, what happens.
Yeah. Uh-huh. Got it.
Is there a thing I say, or I can notice, I can kind of keep track. Oh, I noticed that when there's a door closed out in the hallway, that it seems like your system shifts a little bit and maybe into more of a freezy place, or you seem to kind of go away a little bit. Like, what's that about? And they might not even notice the door closed.
Mm-hmm.
Oh, like, let's just be curious about that. And the next time that happens, they might go, oh, I just noticed that the door closed. But these are things that are happening outside of our awareness sometimes.
Mm-hmm.
So even though it can seem like everything, we can learn slowly to notice those little things that might shift.
Sure.
Yeah.
And it seems like, depending on the client, maybe this is true for all therapies, but it requires a decent amount of commitment on their part to, this stuff totally sounds doable for a client, but it also sounds like, as far as I understand it, like I perform therapy with some clients, but it's usually really specific circumstances. And I'm not nearly as well trained as a LMFT like yourself or LICSW. But outside of my office, I'm aware that other forms of therapy, you go there, you talk, you may or may not go home with like some sort of skills homework, and then you go back into the therapy office, whereas this one sounds like you're going to, you're really learning a skill the entire time. It's not just talking, for example, or venting about stress. It's really this constant bringing back to conscious experiences, whether they're images or behaviors or otherwise. Am I getting that right?
Yeah, a lot of work of being present, a lot of trying to make sure that the person is present. that they have sometimes some people will call it their observer, that I'm aware of what's happening inside of me. And that's part of my job as the therapist, is to bring that into their awareness a little bit. So I might just notice a little bit of a shift where, maybe the person's telling me a story and they're sitting up, and then all of a sudden they sit back. And I'll say, oh, I noticed you just sat back. And they'll be like, yeah. I'm like, oh, what's that like for you? Like, did that change anything else in your body? Or was there something that led you to sit back? Or, I try not to be like, put them on the spot. It's just a curiosity. Or I noticed you just took a deep breath as you said this. And so they're all of a sudden aware of that. And then we move on. We don't make it a big deal, but but just trying to have them be as present as possible. I had one of the people who was training me said, we want to help people become human beings, not human doings. So sometimes, they're talking about this thing that they have to do or this thing that they did, and like, how are you right now? What's going on in your system right now? So there's a lot of being present. If I'm talking about something that happened a long time ago, okay, and as you're talking about that thing that happened a long time ago, what's happening now? Yeah. I might have been talking about a time where I got really angry and I reacted a certain way, and what's happening now might be that I'm feeling a little guilty about that. And where do you feel the guilt inside? So then we're working with the present, but we can be working on things from the past. And that's the experiencing part, is I'm experiencing now what happened then, or I'm experiencing now my feelings about what happened then.
I'm so glad you brought that up too, because I didn't even think to bring up, some people might not be familiar with the word somatic either, of the body. So
of the body,
yeah. Okay. Let's see. Let me think for a minute.
Yeah.
Okay, so you have, so let's say the guilt comes up, and I could see this going a couple ways. I could see it being that the client notices the guilt, for example, and they want to feel better. And that's where the parasympathetic response comes in. You help them with that. Or I could also see you saying or suggesting, like, just sitting with that without trying to change it. Does that come up? Okay.
Yes. So I think you've said parasympathetic a couple times, of like slowing down the system, calming down the system, letting the system know it's safe. And I'm glad you said that, because it reminds me that what I'm talking about is sympathetic activation.
Right.
That's going to get us into fight, flight, or freeze. And sometimes it's joy, social. Like, there's a little bit of sympathetic activation in play. And playing is helpful. We try to do that too in here, to make some jokes, and sometimes orienting, like I said earlier, looking around. Sometimes orienting can be that I go, oh, I noticed you're wearing this shirt today that says blah, blah, blah. Now we're having a social conversation, and it's connection, and that can pull them a little bit into the present. But your question, I had it 2 seconds ago.
Sure, about like might sitting with something, like, let's say, are there spots where a client might say, here's this uncomfortable feeling, and I would like to do the exercises which help calm my sympathetic system down, the fight or flight system. And is there a place, or have you found a situation where you felt it was important for them to sit with this uncomfortable feeling?
Yeah, most of the time it is important. So really, again, I leave it up to them. I might say, oh, it seems like an important feeling to notice. Or where do guilt, where do you notice that? A lot of times guilt is like in the abdomen somewhere. It's a little bit of a pit in the stomach. And so I will say, well, that, or maybe that showed up last time we were talking about this conversation, but it's there now. Is it pleasant? Is it unpleasant? And they're like, it's unpleasant. Yeah. Is it tolerable? Yeah, it's tolerable. Okay. So even as we're having that conversation, they're sitting with that, because they have to check in with it.
Right.
So they're sitting with it maybe a little longer than they would have otherwise.
Sure.
And getting more familiar with it. And their system is learning that it's not, the guilt feeling isn't a threat. So they can tolerate it. Oh, okay. And then we might go, as you're sitting with that guilt feeling, can you describe that sensation to me anymore? Like, how does that feel? How does it, it's like a pit. Oh, does it have like a boundary? Is it just like right here? Or does it, and you know, as they're describing it, it's diffusing a little bit too, because now they're in their thinking brain, they're paying attention, they're putting words around it. I guess it becomes a little less overwhelming too.
Sure.
Yeah, you know, it fills up like my whole abdomen, but it's definitely heavier on the bottom.
Sure.
Oh, so it's heavier. Like heavier like a bowling ball, or heavier, now we're like playing around with metaphors.
Yeah.
And now I'm like, okay, so how does it feel now? And then it's, well, it's a little bit more tolerable than it was before.
Right.
Do you want to stay with it longer? And it could be like, yeah, or no. And if it's a no, then it's okay. Yeah, so I might say, is there somewhere else in your body that you're aware of that feels more pleasant that you'd like to notice, or change the topic? And
Sure.
Yeah.
Okay. Because you're sort of respecting like what they're able to tolerate.
Yes.
Like, yeah. Okay.
Yeah.
So I'm sure this is like, there's probably a billion answers to this question, but could you give me an example of someone who is here? And I keep bringing up trauma, but I want to make it clear, this is not just for trauma. This is for day-to-day, like, human experience that this can be helpful with. But thinking about trauma, you know, let's say you have a patient who, you know, might have a history of physical or sexual abuse or both, and they have a history of dissociative experiences. Maybe you've witnessed some in your office. Like, what would be an example of successful somatic experiencing treatment? Like, some people stay in therapy for most of their lives. Like, there's cases like that, but what might it look like, you know, otherwise? Or probably most people listening to this, if there's a single person, by the way, most people listening to this would be saying, well, I'm not going to therapy. Like, it's very uncommon for people to think about, at least in my experience, like, they're very uncomfortable about the idea of going to therapy for years. Okay. So whatever the duration is, or if maybe there's a shorter duration, like, what does that look like when that client is done with somatic experiencing, and then they're walking on the street and they're living their life? Like, what's different now?
I feel like was it 2 questions?
I'm sorry. The main question is, what does successful treatment look like to a client after they're done? And then I went off on this jag that probably wasn't helpful about, well, sometimes you're never done, and blah, 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 blah. But really, like, if someone ends therapy, it's a successful termination based on your assessment, and this person has a history of significant trauma and dissociation. What do they look like if they're successfully treated?
Like, what I want to say is just they wouldn't have as many sneaky surprises of dissociation. They may still dissociate sometimes, but they may have a better understanding of why. And it would be totally up to them whether or not they want to continue working through some of those things that maybe would cause them to dissociate. But I think that's where the trauma gets bothersome for people, is when they don't have control over it, or it just sneaks up, and they're going through their day, and the next thing you know, they're having a panic attack, or they're dissociated, and so getting them to a point where they understand their system, but really up to them as to whether or not they want to continue.
Sure.
But there's people that come in with a specific trauma, and that's what they want to work on. And somatic experiencing can be really helpful for that too. Like, they were in an accident, and they want to work through, you know, maybe they're still having trouble a year later sleeping, or driving again, and we can work on that event. And what success looks like there is that usually that they've been able to sort of renegotiate it in the moment, understand like, well, right before the accident happened, what I was doing, the song. Maybe I remember all of a sudden what song was on the radio when it happened. This, maybe there's a push response that wants to happen, or a run response, and we can kind of negotiate that in the session. A lot of times surgeries, we can work through some of that as well.
Trauma associated with surgery. Yeah, okay.
Yeah.
Okay. So this is another tricky one. I like to ask these two because the listener I'm trying to speak for is the one that is, just not versed in this stuff. So let's say someone has a history of panic attacks, and that's what they want to work on. If they say, think of in your office, like, look, I really want to work on panic attacks. They seem to come up out of nowhere, and here's the story with that. The dog bit me. It's a classic dog bit me, and I have panic attacks when I see dogs. Can you give some idea generically about how confident you are that you can resolve this issue for them? That's a hard question, but again, sometimes I'm going to give you an example if this is useful. Sometimes I'll meet clients and I'll have some idea based on their story or their med history how confident I am I can successfully treat their depression or anxiety. Sometimes I try to make things concrete because I think that is helpful for some people. And it's a very hard question because you can't predict the future, but yeah.
Again, like, my first response is, I don't know that I think of that as my job.
Resolving the...
Yeah.
Okay.
The next thing I want to say is, I guess I can assess how open the client is to trying new things or thinking sometimes a little bit differently about something. And if they're like, this is my trauma, this is my response, this is who I am, I know right off the bat that it's going to be a little harder too.
I see.
Because it's sort of part of their identity at that point, and I don't want to change anyone. And also, I don't look at it like I'm trying to fix someone. And I don't know that I want them to be in a mindset that they're trying to fix themselves either. It's sort of, can we just both be curious about this thing that happened, and how did your body learn to respond? And can we try to create sort of a new roadmap for your body, for your system, so that it can react to these similar stimuli just a little bit different, and just a little bit different. And if they're open to that idea, then I feel more confident that we're gonna be successful.
That's that's an interesting point, which is, I told you that I like to meditate a lot, and I have this thing on my computer, it'll remind me, it says there is no problem to solve. And the point of that is that, like, sometimes people get, and I think this is what you're saying, sometimes people think that they have one problem, but it's not the problem they think they have. Yeah, and so if they can see things differently, because you can totally appreciate the person. It's like, what are you talking about? I have panic attacks. That's what's impairing my job. I want the panic attacks gone. And so anything that's not about getting this panic attack thing is completely not for me. And if I'm understanding you correctly, you're sort of saying, well, I might not be able to resolve the panic attack issue, and yet they might get a perspective that could solve the panic attacks, but they might not, they might not have the same relationship with that problem they used to. Yeah. They might see wider and other options that just weren't available prior to somatic experiencing therapy.
Yeah, because just the normalizing of it, just saying to someone sometimes, like, that panic attack is a good thing. I think I try to say it like that, and I think it kind of cracks people up sometimes because they're coming in with, like, and I'm like, oh, it's a good thing that your body's doing that. And they're like, what? I'm like, well, it just tells me that your nervous system is working really, really well. Like, it might be responding to small little stimuli that aren't threats anymore, but it learned to do that over time. And we can try to unlearn that. But that in and of itself can sort of, if we can lower the threat right now, because if I'm looking at the panic attack as a threat, then I'm my sympathetic nervous system is already more elevated. So,
yeah, you're sort of reinforcing this thing as a threat when it's actually not,
yeah,
like this sensation
right.
of panic. Okay.
Yeah,
Okay. How are you doing on time, by the way?
I'm good.
Okay,
I'm
good.
free. Yeah.
Okay. How about if you have a patient come in who they might be in a romantic relationship or they might be struggling, like have a history, and they say to you, you know, I just like I don't feel like I really attach to people, and I know that they're good people. So instead of there being a threat, like I'm sort of imagining somebody that's like, who knows what's going on with them, but maybe one way to look at it is that they're sort of under stimulated in a situation they'd really like to be, you know, which is being in love with somebody.
Mm-hmm. I go right to safety. They wanting to be with someone is what you're asking, maybe.
They want that, and they're sort of discouraged and sad about, I just don't feel like I'm connecting with people, and I don't know what's wrong with me. And you know, I like it's a very complicated example because there's so many things, right?
Mm-hmm.
I guess what I'm really wondering though is, or let's say that it's sort of like anhedonia, so this lack of enjoying things that you used to enjoy, okay? And how might you approach that?
Mm-hmm. Yeah, I think safety and noticing, well, in the moment, what is it like to be you? You know, sometimes there's that sense of, oh, I should be doing this, or I should be doing that, or I should be with someone, or if I was loved, and sort of in the moment helping someone to notice, are you okay right now? Is there a threat? Is there something that you should be doing right now that you're not doing that's preventing you from being the person you want to be in this moment? And most of the time, the answer is no. You know, well, you're here, and you've made a choice to be here, but I feel so sad. Yeah, and you know, then we're noticing the meaning, and what is the story that they're telling themselves about themselves that's making that sad feeling, or that being without a partner or something not okay for them. So I kind of go back to the idea of being a human being. What are the things that maybe bring you joy? When was the last time you felt joy? Well, maybe like I was riding my bike when I was 7 years old. Oh, tell me the story about you riding your bike when you were 7. Well, I remember I was doing this, and like notice your hands, like in this moment you're actually riding the bike, and you feel that in your body. And in that moment, now they're describing this joy that they had when they were 7, but they're actually experiencing it in the moment, in their system, right here in the session. And it might be just this little snippet of time that we're having that conversation, but they got to kind of relive that and hopefully carry it out of the room with them.
Sure. They get some practice accessing that.
Yeah.
That. Yeah. I keep wanting to say sensations, but it's the sensations, images, and behavior, all these aspects that they get a piece of, and they get to remember in a way of like what that experience is like of joy.
Yeah.
Okay.
Mm-hmm. And
okay.
I think that I don't know much about EMDR, but I think similarly to EMDR, we do a lot of resourcing.
I don't know what that is.
So a lot of finding places of joy or places of comfort, places of, and I say places, I don't mean outside in the world, I mean in our nervous system.
Mm-hmm.
Trying to think about my own personal, sometimes just like holding a hand, I can go like this and it feels comforting.
Mm-hmm.
So I might help a person to notice what they're doing in their system, in their body, that feels safe and comforting.
Sure.
And maybe it's wrapping up with a blanket or something.
Mm-hmm.
There might be images that come with that. So really, we're going to start with, like we kind of talked earlier about, like going right into the trauma story. Usually, it's going to be helpful to start with, where are the places that you feel most like you? And it might be the answer, like you just said, like I haven't felt like me in years. Mm-hmm. And we want to try to find, when was the last place you did, or when was the last time you did. Who was the last person you were talking to who you did feel safe with, who you did feel that connection? To help a person to have a place not only in their mind but in their body that they can go to that is safe, that is comfortable, it does feel like them. And then hopefully they can even go out, and I might give a little bit of not real homework that I'm going to check, but it might be interesting to go, as you're out in the world this next week or so, notice if there's just 1 second where you get that same sort of feeling, or where it feels familiar in that way. It might be, when I was climbing a tree, but they find that they're walking outside and they all of a sudden there's a tree that looked a lot like the tree that they were climbing when they were little that they remember was bringing them joy. So now they just pulled that into their actual life. Now that tree can bring them joy again, even if it's for a second as they're walking by.
Got it.
So that's resourcing. In a traumatic story, in a moment where they're feeling more activated sympathetically and uncomfortable, I might say, remember that story about the tree? Or remember riding your bike? How is that memory? Or are you able to get there now? And it might be a place where they can go, or even in the session. Oh, I love the candle in your office. And that's a resource. Oh, yeah, what is it about the candle that you like? And then, it just gives me warm and fuzzies. Oh, where is that? And then later, as they're talking about something hard, we can go, let's just maybe notice the candle again.
Got it. Okay. Yeah. Got it. All right. I see. You had pointed out something before we were recording about a patient with something like that, and so I'm thinking back to that now. Yeah.
I don't remember it. Remind me.
I might tell you. I don't know if it'll give anything away about this person.
Maybe
So
not.
yeah. So do you meditate?
Not as a routine.
Okay.
But yes.
It would seem like, because this really resonates with a lot of at least things that I've learned, and it would almost seem like it would sort of be required training. I mean, when you're training in it, I mean, I don't know if you go back and forth with a fellow student about just, as you would with a client, where are you noticing this? But it would seem, again, this beginning example you gave where you were very articulate about what was happening in your body, as you said, that doesn't come in our culture, unfortunately, at least not when you and I were growing up. There's not that sort of teaching. And so it would seem like you'd have to get there. And you said you had this experience yourself with your own therapy with somatic experiencing.
Yeah.
Where does that come from otherwise?
Well, I think that was a lot from that, from therapy. And my therapist would say things like that. I would say, I should go to this person's birthday party. And he would just say, you should, that's it. And I would be like, and then he would say, oh, yeah, who says you should? And I would bring my awareness to the words I was using. Or you sat back, or I noticed that as you're telling me the story, you're looking like you want to just jump off your chair. So it started to help me to notice that, I did do yoga. He recommended yoga to me at one point, and so that yoga was helpful for that because it is very grounding, and there is a lot of times a mind-body kind of connection there. But yeah, if we're training for a somatic experiencing too, we do have to every day during the training we we go into groups of 3, and we do little mini sessions with each other, and then we have to get training with other certified practitioners, so we have to do a certain amount of our own individual sessions with a certified practitioner because it is so experiential. You have to be able to do it yourself and know what that feels like.
Right. And
to know that it is hard too. I think that I do have patients that will say, I kind of get the feeling like I'm supposed to know how to describe this sensation in my body, but I don't know, and that's okay. To really make that okay, I'm not. There's no expectation here. I'm not expecting someone to know those things, but we're learning and practicing it, kind of as we go, and we celebrate those moments when they do when they come in and they say, I was in the store and I just noticed that my body was tightening up and that I stopped just being able to think, and I had tunnel vision. And then I took a deep breath and I looked around and I reminded myself that I was in a safe place. They don't necessarily know what it was and this external stimuli that was telling them that there was a threat, but they were able to notice what was happening inside.
Right.
I was like, oh my gosh.
Yeah.
Yeah.
Right. And then they have a more tolerable or pleasant experience, with what they're dealing with.
Yeah, they can regulate it.
Yeah.
But they learn it. Sometimes they're learning that in here, in the moment.
Yes.
Yeah.
Okay. You gave a good example of something a moment ago, which was, you said that I should go to the birthday party, because I could see someone too in your sessions or listening to this making the argument that, well, sometimes you just have to do stuff. Like sometimes stuff is like a legitimate problem. Like maybe I have a bunch of work to do, and so there is benefit in, or there doesn't seem to be a way out of stressing out that I have a legit problem. And then the birthday, I was imagining that thing we all run into where you want to go perhaps, but you also feel a little bit of obligation, and maybe you'd rather maybe stay at home or something, but you feel like I could damage this friendship, so how is that looked at in somatic experiencing, that type of thing where but there is something to do here?
Yeah.
Or I feel compelled that there's something to do.
Well, that's a great word. Yeah. So there's this impulse to do something. And we're noticing impulses. Sometimes it's starting off with I feel an impulse to eat. I feel an impulse to go to the bathroom, and really giving yourself permission to do those things when you want to do them. And then changing it from a should to a want. And someone, like you said, sometimes it's like, well, I don't really feel like it's an I want to do this. And so there it's sort of going back to who the person is. Sometimes it's I should do this thing. I should reach out to my father because it's the right thing to do. And then sort of going, well, where in your system is it saying that it's the right thing to do? Is it coming from out here? Is it coming from in here? And sometimes people will say, yeah, it's coming from in here because it just feels like it's the right thing to do. Okay, well, is it something that you want to do? Well, no, I don't really want to because it's going to go this way and blah, blah, blah. We kind of just sort of, sometimes what the should is that this is more aligned with who I want to be as a person. And going to that party or calling that person, I'll feel like I did what is important to me. It's stuck with my values. And so then it's a want. It's not a should anymore.
Sure. Okay.
Does that answer that question?
Yeah, it does.
Yeah.
Okay. So they're kind of accessing that part of them in this case where, well, I am a person who wants to be aligned with my values, and there is, it sort of changes the picture for them about, God, this is something that's just going to be draining, and I'm debating with myself, should I do it, should I not? And then, at least in this example you gave, well, that's one way of looking at it, is that this thing that you don't want to do, but you feel like you should, it's going to be draining. And then, let's explore that. Is there, what part of you is resonating with the should, and it might be a values thing in this case. Okay.
And that's sort of also maybe to explore what the threat might be. Maybe there's a reason that you don't want to call your dad, or you don't want to go to the party because your body is picking up that there might be something that's not going to go well. That might be like a threat. So then we can go, let's think about ways that you might be able to still do that safely. Still do those things and feel within your boundary, feel like you can protect yourself, that you can show up to that thing as you, not as what maybe somebody else expects you to do, or how they expect you to show up. Yeah.
Okay. Are there any populations you would say, off the bat, are probably not good candidates for somatic experiencing?
there tends to need to be a little bit of a... That's a hard question. I don't really think so, but I'm trying to think of some of the people that I've seen that can be harder to work with in the sense that they don't want to try new... It's like speaking a little bit of a new language. On the other hand, they might be the people that I won't push. And I don't push it in general, but like I might just let it go. But then I find that over time, because it's just my natural way of interacting, or I might use more of a, well, geez, I'm noticing in my body this thing. And I don't know if that's because I'm empathizing with you or if it's just something about me in this moment. And then I find that those people tend to pick it up anyway. And the next thing you know, we are doing it, and it's okay. So I could say sometimes there are people who it's just not a good fit. I wouldn't say a specific population, though.
Sure. Okay. Okay. So in some ways, like, you know, because there's certain barriers that could get in the way of other forms of therapy. Like I'm thinking, for example, maybe this is true for somatic experiencing, but I know for some forms of trauma therapy, you can't proceed if the person's still living in a traumatizing environment, for example. Have you heard that before?
Yes.
Yeah.
But no, I wouldn't apply that here.
Okay. Great. Okay. Cool.
Because we're really just helping that person, if they're in that situation, you know, maybe notice what are the defenses that they want. I really want to yell at this person, or I really want to run, and imagine what that would be like. Sometimes we can picture that. We can play with it in the room, run in place, imagine what it might be like, and then they can get a little bit of a view of what they might, maybe what a goal might be. And also normalizing that it's okay to be where you are right now, and that this is what's safest for your system right now, even though this situation might be really hard and there may not be a way out because this is what is necessary, or the person might not be ready. Finding ways to keep themselves as safe as possible in that place, and their system usually just knows what it needs, but we just have to kind of open up the space for it to tell us. We have to have it. Our body doesn't usually tell us what we need if it's not safe enough to share. I know what people, like, they'll come in, they'll start having dreams, nightmares, and I usually celebrate that a little bit too, because it's like, oh, your nervous system must be safe enough right now for your unconscious mind to start giving you information about things that you need to know about yourself. And so if we're safe enough in here, if their system can be safe enough and stay regulated enough, they can usually get a little bit more of an awareness of what they're needing, even if they're still in those situations that are not, you know, ideal or really what we would consider safe.
Do you ever have to have clients take a break from therapy? Because I know I've run into before some clients, like, it's really common for people with a history of trauma. I don't know how common it is, but I've certainly seen it where it's recommended by the therapist or by other people on the team to say, you know, I think we need to back off right now because they're having more problems of some kind, and they're, you know, at school, or they're depressed, or they're having, you know, I work a lot with kids and teenagers, they're having behavioral problems, like becoming more aggressive or something like this. And have you ever had an experience like that where there was something that could be, like, not helpful at the time in terms of the therapy you were doing with the client?
Yeah. So depending on what life circumstances are going on, or they might get pre-activated from working through something. Yeah. And so then we'll just sort of not necessarily take a break from therapy. Depending on what they're wanting, they might still want to come to therapy, but then we're using that time to do more of the resourcing than to do the titrating with the activation. And
Got it.
working on that.
Okay.
Yeah.
Here's another question I have for you. So I've also learned from therapists, well, in my own training, that so you might be familiar with what a benzodiazepine is. They're anti-anxiety medications that are controlled substances. So Ativan or Klonopin or Valium are examples.
Yes.
And so typically, as far as I understand it, those are not like, they don't tend to help trauma therapy. Okay. And part of the reason for that is because if the patient is having, world experiences that are, causing these traumatic responses, and they have a pill that can just suck all that anxiety away, well, then they're not actually dealing with the core issue. They sort of have a solution, but the problem with this solution is that it could stop working. Certainly addiction can occur with benzodiazepines, tolerance, so you have to keep upping the dose and that sort of thing. So I've had two situations that I can remember where one of them was a client who was having so much, like, so many panic attacks and trauma, like she could have lost her job. Okay. And so I thought, okay, I'm going to prescribe this short supply. And I always check in with a therapist. So I had that experience with a benzo. And ultimately, I don't know. Like, I don't know if that was helpful or not. Again, it was a short supply, not like a 30-day supply or something. So it's like, okay, can you have the experience of feeling calm? Because my experience is people who, sort of like you're accessing the bicycle memory. If they can live the experience of being calm, they kind of can learn from it as well, and they might learn how their body feels differently. And I've also had, this is a double question. One is about benzos. The other is about what are called antidepressants that are also used for anxiety. So an SSRI like Prozac or fluoxetine, Prozac or Lexapro or Zoloft are examples of those. And I had one therapist who I respected who was very concerned that I was prescribing it for someone who had anxiety and was seeing that therapist for anxiety. So what I've always learned is, like, the gold standard of treatment for, say, generalized anxiety or major depressive disorder is, the use of a medication and therapy. So I hadn't run into a therapist who did not feel comfortable with, like, a non-addictive, substance like an SSRI. She was concerned that that was going to interfere with the client learning these skills or being motivated to. So I would like to hear what you have to say about that.
Well, I'm not an expert on the medication piece at all, so I never really feel confident in telling anyone whether I think it's a good idea or not. I would trust someone like you to say whether you think it's going to be helpful for them. But as far as interfering with therapy, I think it would just depend on the stage that we're in. If it's going to help our nervous system settle down, and like you said, give them an experience of safety. If they're coming in really not, their body's not feeling safe, we're not going to get much work done. So I think maybe in the beginning, to be able to get some of the skills, to learn some of the language about sensations, and to start making some connections, maybe building rapport. And I think with what you were saying, to maybe over time they can, as they feel more confident in their own ability to recognize what they're experiencing, maybe that would be a time to sort of consider coming off the medication or lowering the dose if that's safe to do.
Yeah, that's helpful, because I think that, just as I said, there's some therapists that would not say what you said. And I think that highlights, like, I appreciate your humility in terms of, okay, well, I'm not the medication prescriber. I believe there's this inextricable importance of a prescriber working with a therapist, at least in many cases. Sometimes it's not actually necessary, but when there's a borderline question like this, because first of all, the therapist has a lot of training in the therapy and what can create problems in it. And then also, as you said, specifically what's going on. the therapist's own experiences. We know when they've seen clients that are medicated with one thing or another, and then also, yeah, like how that therapy modality, like, kind of as you explained, if there's something that can help the nervous system calm down, or if it's helpful initially. So I don't know that there's a perfect answer to this question. I just like to ask different therapists that, because it seems like one of those borderline things where ideally, yeah, the therapist and the prescriber are working together. The other thing too, I probably beat this drum with the people I've interviewed, but I actually think it's really important for therapists to bring up medication, because they're the one that sees the client the most. And so they're going to have, in my opinion, a better assessment than any prescriber. Prescribers don't see the client every week, typically. I think we can run into trouble when a therapist or someone else recommends a very specific medication, because that usually does take a full, like, assessment of the patient to really know, okay, what's actually going to be the right thing for them. But I think talking about meds in general, or consulting with the prescriber about, I'm a little worried about this. Like, I've always appreciated that feedback from therapists. If that's how I learned that certain meds, could interfere with therapy. Yeah.
This, I guess, would be a thought I'm having, plus a question for you even, is that I would think it's also important to make sure that the client is fully on board with taking the medication.
Absolutely. Yeah. So that's a good question, because I would like to think that that's a given, but you're right. Some prescribers might be more aggressive in pushing something than others. But I definitely make it a habit of telling people they don't have to do any of this that I'm saying. They can stop it anytime they want. I'm not going to pressure them to stay on it, but some meds have to be tapered, so just tell me if that's what you're doing. But yeah, so that's another good thing to say, since this is being recorded. If someone has a prescriber that's pushing a med, or that's a problem, like, that's a big problem. Like, yeah.
Because what I'll see is sometimes clients saying, I should be taking this. It turns into a should. And the should can be because their prescriber said so, or because they want to feel better. And that's some of the things we can work out of, like, well, is it a should or is it a want? Or is there parts of this client that really feel ashamed of having to take a medication, or but I think that can work against them. So even if they're taking the medication but they're feeling ashamed of taking the medication, I don't know that it's going to do its job. So sometimes I'll try to empower the client, like, if you really don't want to be taking it, it's probably not going to do you any good to take it, because then, in a sense, it's another trauma. It's another thing that is happening to them that they don't feel they have control over. So
yeah, absolutely.
Yeah, I could see that as a way of someone like you or someone like I working together too, to clue each other in on what's needed and maybe some of what the client is struggling with.
Absolutely. Yeah. And then too, clients, they might feel more comfortable talking about their medication situations with their therapist over myself. They might have more to say about it, or things not occur to them when they're in my office. Yeah, that does come up, though. Like, there are situations where, especially patients, it's common for, I see it more in women. And I don't know if that means anything physiologically or about how different sexes handle trauma, but who have a history of trauma, and they can have a lot of somatic experiences that are uncomfortable on medications. And so you can try stuff that generically rarely cause side effects, and they can have a bunch of uncomfortable feelings. And so I think that's a case where I do think prescribers can be more pushy, because they're frustrated, or they don't believe the client, or everybody just wants their client to get better, and they can feel like a failure, this sort of thing. I'm trying to think about this and really question myself. I think the closest I get to pushing a med is if I have a kid who is dangerously aggressive. And I think in those cases, I tell the parent, it's really important they get this. Like, or if they don't want their kid on it, okay. And I just need you to have this information that I'm extremely concerned that they're going to hurt you or someone else. Like, that's my concern. And as long as you can hear that risk and understand it, then yeah, it's your child, and
Yeah.
then yeah, I don't have anything to say about that. Yeah.
Mm-hmm.
But those, I
Yeah.
think, are the times I could think of where I probably, yeah, said I think this is really important.
Yeah.
Yeah.
I can't see it being pushy.
Yeah. Well, thanks. Yeah. Yeah. Okay, and also too, I want to ask: are there other things, like, in thinking about the intended audience, which is, I don't know what better word to use than lay people. We're all lay people with something, but like people who aren't that hip to psychology or psychiatry, like other things that you would want people to know, or people that have misunderstandings about this.
About somatic experiencing.
Mm-hmm.
No, it's just a really gentle, affirming, empowering modality.
Mm-hmm.
Yeah, and it's really driven by the client.
Mm-hmm.
And it, well, probably like any therapy, I think it's sort of, it changes your lens.
Mm-hmm.
Yeah.
Yeah.
Mm-hmm.
You have done a good job of emphasizing that, like at every, appropriate time. You've said how, yeah, the client has a lot of control and decisions to where they're deciding, not you, about where they want to go, what they're comfortable with. So I'm glad that was something I didn't know prior to talking to you. So
Yeah, that can get kind of tricky sometimes when working with people who do come in with like an agenda and want goals. They want me to be driving, and then that's not me, and that's also not this modality. It also can get tricky when working with other practitioners, maybe like primary care.
Yeah. Or psych prescriber.
A psych prescriber
Yeah.
who wants us to really detail what we're working on. What are the goals? What are, and it's hard to describe. Our goal is to be more present, be more authentic, be more embodied. Like those things don't usually make much sense.
I think you've done a good job of explaining it here. I mean, you said you're working on your elevator speech, but it sounds extremely useful. It's very much in line with being present with what is, which is not usually nearly as threatening, is people's thoughts about the future and past, like when they're stressed. So I think it makes a lot of sense. So yeah, I'm glad you
got that out of that.
Yeah. Yeah. Anything else?
I don't think so.
Okay. Well,
No.
Thanks a lot for doing this, Val. I
Thanks,
appreciate
Jordan.
it. Yeah.
Yeah, thanks for asking me.
Totally.
It was fun. It
Good.
was a lot easier than once I got settled.
Yeah, sure. How much you used your somatic experiencing skills.
Yes.
Yeah. Good. Cool.
Yes.
Thanks again.
Thank you.
Let's see.